Thanks, John, and thanks for the invitation to speak today. I'm not sure you're going to learn much about the nuts and bolts, more about what we don't know, but that's okay. So just my disclosures, not relevant here. But so you've heard from John, and you've heard from Danny and Neil. You know, adaptive platform trials really have changed how we generate clinical evidence. But as a health economist, you know, I spend a lot of time speaking to policymakers, and the clinical evidence alone is never enough. And I think we forget that the people who are making the decisions from beyond the bedside need to understand cost effectiveness. They need to understand value for money, or they're not going to allow interventions to be used, because you can have an intervention that might show clearly that it reduces mortality by 0.1%, but that costs $30 billion. Now, any government funder is going to say, look, really happy that you reduced mortality, but actually we just can't afford it. And so that's where health economics comes in. So I spend my life telling my children that money doesn't grow on trees. One day I hope they will learn that. They are yet to learn that. And it comes about this. We have unlimited wants. You know, if we could all do everything we could, we would. But we don't. We have limited resources. I gave a talk once at an ANZICS conference in Adelaide where I used to show, you know, how did people get to this conference? You could fly the budget airline, you could fly the routine airline, or you could fly private jet. The best bit was there were 2 intensivists in the audience who had flown private jet, and I knew that. So, you know, but when you make that decision, it's all about, well, what benefit do I get for how much it costs me? We all make these decisions every day in our own lives with how we spend our own money. But for some reason, it just doesn't get incorporated as much into the clinical research space and into the clinical space. And I've been working in health economics for a very long time, and I regularly have clinicians say to me, well, I don't care what it costs. And I said, but if it was your money, you would care what it costs. And it is society's money, and so it really does matter. And so the trial funders are now requiring robust evidence on value for money, so that we, in most healthcare systems, well, depending on, you know, we have finite healthcare budgets. And so decisions about what to spend that budget on needs an accurate estimate both of the costs and the health outcomes. And so that's where cost effectiveness analysis comes in. So we're going, okay, well, what is the risk benefit? Now that's routinely what we do in our clinical research. We look at the risk benefit profile. You know, is it worth doing this intervention from a clinical point of view? What cost effectiveness does is it says, okay, we're going to take that clinical evidence and now we're going to look at the costs of it. And the important thing, it's not just the cost, for example, of the intervention. You know, you might have a really cheap intervention, but there might be downstream effects where, you know, if you know, my primary basis is in intensive care, it might increase the time on ventilation, or it might increase the need for renal replacement therapy. You know, it might do things that have significant downstream cost effects. And so when we do health economics, it's not just about what we're implementing going to cost. It's about what are also then all the downstream impacts of doing that. So as I said, we have limited resources, and then we have this concept of opportunity cost, which I'll go into in my next slide. Unfortunately, when we come up with new technologies, for some reason they always cost more. It would be really nice if we had new technologies that were cheaper, but that's very rare. And so what we have is we have available resources, and we want to maximise the benefits given those available resources. So in a hospital, it has a set number of beds. It has to determine which patients to put in those beds. And when you're down to that last bed, if you have more than one patient, you are making a decision about which patient will benefit more from this bed. So opportunity cost is the value of the best alternative foregone. So what we're trying to do when we do economics is to ensure that the activities that we choose to do have benefits that outweigh their costs. So I am standing up here now giving you this talk. I could be going and doing a tour of Dublin Castle. So I've clearly made a decision, may not be the right one, that the opportunity cost of being here is better for me. And that's what we're doing when we're making decisions to do things. We are looking at the opportunity cost. And it's not just money. It's things like ICU beds. If I put a patient in that bed, it is not available for another patient. Or if I take this nurse and give them this task, they are not they are now not available to do another task. And so it's not just about the dollar money, it's also about the resources we have and how we allocate them. So this is a general question. So if there was a treatment that we knew improved survival, but it doubled healthcare costs, would we do it? And it's hard, for me, I say, well, it would depend how much it improves survival by. If it improves survival by 0.1%, but it doubles our costs to the healthcare system, not something I'd do. If it halves mortality across the world, then yeah, I probably would, because the downstream effects of that halving of mortality with increased job productivity and all of the aspects outside the healthcare system would probably make it worth it. I do a lot of work in ECMO, and I spent a lot of time speaking to ECMO clinicians about how expensive ECMO is, and Danny's sitting in the front row. But I spent a lot of time saying, if you put a patient on ECMO, you could have given 3 patients bypass surgery, or you could have given 9 patients a total hip replacement, or 290 patients could have received mental health care treatment. So when you put that one patient on ECMO, 290 patients are not getting mental health care treatment. Now, that's a very broad generalisation, but we do have finite resources. So when you do one thing for one patient, that is taking away resources from another patient. And so I spend a lot of time with this statement. We can't spend infinite sums of money on marginally effective treatments. Things might work, it doesn't mean we should do them, because we could take those resources and get more health gains somewhere else in the health system, or somewhere else outside the health system potentially. So just briefly what we do in health economics, and there can be more than 2 things, but generally we're looking at, let's say we've got a trial that's got 2 arms in it. We're looking at a domain in a platform trial that's got 2 arms. We compare those 2 arms both in terms of their costs and their effects. And effectively what we're doing is coming up with what we call an incremental cost effectiveness ratio. So we're saying, what's the difference in cost divided by what's the difference in effect? The lower that is, the better that is, because it means I'm not having to spend much to get an effect. So you may have seen, this is called the cost effectiveness plane, and you may have seen these before. Generally, things fall into 4 quadrants. We work out our incremental cost effectiveness ratio. We sort of work out 95% confidence boundaries around them, but there's a few statistical complications with that, but let's just assume that's what we do. If things fall in the bottom right quadrant, that's fantastic. They cost less and they're more effective. That is extremely rare. It's happened to me once, though. It was very exciting. If things fall in the top left quadrant, they cost more and they're less effective. Clearly not something you want to do. They are very rare quadrants for cost effectiveness evaluations. Typically, things fall in the top right quadrant. They cost more, but they're more effective. Now, when that happens, you then have to make a decision about, well, what am I willing to pay to get the extra benefit? And so what we usually have is a thing called a willingness to pay threshold, where the government might say, I'm willing to pay 50,000 euros. You have euros in Dublin, is that right? 50,000 euros per quality adjusted life year. That's a line that you can plot, a linear line that you can plot on that graph. And if you fall under that line, then it says, okay, you fall under what we're willing to pay. So it's worth it for what we're willing to pay. If it falls on top of that line, then it's not worth it. We have to pay more than we're willing to pay to save a life, or than we're willing to pay to improve someone's quality of life. The bottom left quadrant's really tricky. I've done multiple recent health economic evaluations that fall in the bottom left quadrant. So things cost less, but you get less effect. Now, in theory, if you were just talking pure economics, you would have that same threshold applying that applies in the top, because if we save enough money, even though we're getting less effect, that money can be put somewhere else in the system to get better overall effect for the healthcare system. But it's a big ask to change something knowing it will reduce outcomes because of the amount it costs. So let's get on to platform trials. So this is a systematic review that might only be online at the moment. I don't think it's actually published yet. So they wanted to identify platform trials that had available master protocols. so they could evaluate what was happening with health economics. So they identified 104. This is across 3 clinical trials databases, so clinicaltrials.gov, the Australian and New Zealand clinical trials database, and the World Health Organization clinical trials database. So of the 104, only 17 had planned health economics, and only 4 across 3 platforms have actually published health economic evaluations. And I'll come to why in a minute. But for only 17 to plan them is really problematic when we are talking how to treat patients. And I think it's a huge problem to only be looking at clinical effectiveness, because that just doesn't work for governments, for funders. So we're transforming evidence generation with adaptive platform trials, and I'm a huge proponent of adaptive platform trials. The problem is economic evaluation has not kept pace. So our current methods for economic evaluation assume we have a fixed design, they assume we have a fixed sample size, and they assume we have unbiased treatment effects. And adaptive platform trials don't follow those rules. And so the problem is that standard health economics methods fail in adaptive platform trials. And so you've got 17 planned health economic, of the 104, there's only 17 planned, there's only 4 published, mainly because we don't have the methodology to do them yet. And so the 4 that are published don't actually account for the challenges. So, whether they're particularly accurate, I would question. And so we know that generally adaptive platform trials, some of the features in adaptive platform trials, like your triggers, can produce biased estimates. We still believe the result. We still believe that works doesn't work result. And so from a clinical point of view, I think that's okay. And depending on your outcome and things, the magnitude of it is small. But in general, an adaptive platform trial can increase the risk that the observed treatment effect is larger than the true treatment effect. We still learn the treatment effect. We just don't know its exact magnitude. So that doesn't really matter from a clinical evidence point of view, but it really matters from an economic point of view. So let's look at an example. So random high estimates in adaptive platform trials are more likely to trigger stopping, because we say if the probability that you are above this particular effect is X, we will stop. Now that can just occur by random chance. And I know, for example, in Remap Cap, we've put in a lot of guardrails to prevent this. So we now have things like there must be a minimum sample size in a domain before you can trigger. So you're not getting a result early that actually was just a random high. And there's some really important learnings for adaptive platform trials about how to prevent some of these problems that occur. Obviously, we do regular adaptive analyses in adaptive platform trials. Obviously, every time you look, there is a chance that you could look at the time where there happened to be a random high that led to a trigger. So even if the treatment effect is moderate, eventually one adaptive analysis might just look unusually favourable, not because it's the true effect, it's just you happen to look at a time where there was a random enough high that the probability distribution enabled a trigger to be reached. So let's say we've got a treatment and we know the true effect is it reduces mortality by 2%. And by the way, we don't have treatments like that in ICU anymore, but let's just pretend. If we're examining data, it could be that at month 1 and 2, it appears 6%, just because we've got a small sample size. Now, admittedly, we'll still have a broader distribution, but there is the possibility that you just happen in smaller numbers of patients to have some particularly high effects that you then trigger. Now, if the trial looked at month 1 or month 2, let's say it triggered at month 2. So we trigger saying there's a 6% reduction in mortality. But we know that the true effect is a 2% reduction. Now, from a clinical point of view, that's fine. It reduces mortality. It doesn't really matter how much it reduces mortality by. This is something clinically we would want to do. But health economists don't care directly about the treatment effect. They care about the cost effectiveness. So the true effect is that there are 2 additional survivors per 100 patients. Let's say we observed we triggered at a point where there were 8 additional survivors per 100 patients. If our economic evaluation uses that 8% estimate, then the treatment appears more effective, which means you have more QALYs gained. So QALYs are quality adjusted life years. They're the routine measure in health economics because you can compare across different interventions across different parts of the healthcare system, and they're just a combination of quality of life and length of survival. But when you have more QALYs gained, if you remember that ISA I said, so the ISA is the costs divided by the effect. If our denominator, if we're saying our effect is larger, that makes our, if you remember back to Maths 101, larger denominator, our ISA will be smaller. That makes it look more cost effective. And so something that the true effect, had we known the true effect is 10,000 euros per QALY, might actually be 40,000 euros per QALY. Now, it still reduces mortality, but the cost effectiveness impact is huge. And at the moment, we don't have great methods in economics to adjust for this. There are some ways to do it statistically that don't transfer particularly well to when you're using a ratio and when you're doing economics. And so a small bias in a treatment effect that perhaps doesn't have a huge impact on your clinical conclusions has a huge impact on your decision about value for money. Now, we have other problems in health economic evaluations. So obviously, domains like REMAP-CAP are multi-domain platforms. And so when we're looking at costs and outcomes, they actually reflect a combination of interventions. And so we have a wonderful unblinded statistical analysis committee in REMAP-CAP who can adjust for the impact of all of the other interventions. So the decision has to be made, well, should we have an unblinded health economics team as well? Because at the moment, as a health economics team, we can't adjust for the interventions that are still ongoing. So we don't have access to the allocations that are still ongoing, which if for some reason they're not balanced, we can't adjust for them. We will get very biased effects. We will potentially get biased results in our health economics because we can't adjust for allocation to those open domains. And statistically, that does happen with the unblinded statistical team. Obviously, you're increasing the costs and things of a platform trial if you're saying, okay, well, now we also need an unblinded health economics team and a blinded health economics team. And, it's really challenging from a funding point of view to be able to do that. So if we have a patient getting steroids and anticoagulation and immune modulation, if we were doing an analysis of the steroids domain, neither the anticoagulation domain or the immune modulation domain had finished at that time point. So we wouldn't have known about the allocation to anticoagulation and the allocation to immune modulation, both of which triggered, one triggered for harm, one triggered for benefit. And so if there was an imbalance in those that we didn't know about, we may have come up with an assessment of value for money that wasn't an accurate assessment, and yet that's how funders make decisions. Just a couple of other challenges. These are not APT-specific challenges, but nearly all adaptive platform trials are multinational. Having things across countries is really challenging for health economics. There are huge differences in healthcare systems. So things like the funding models, the care pathways, even things like staffing ratios. If I talk from an ICU perspective, staffing ratios can differ greatly between countries. That really influences your cost effectiveness if you've got one nurse treating one patient versus one nurse treating two patients. There's variation in unit costs and prices. So resource use you can sort of transfer between countries. The costs of those resources differs hugely between countries, and that influences, obviously, how do you do an economic evaluation across countries. There's huge clinical heterogeneity, so the baseline risk differs greatly between countries, as does the standard care. So, for example, and I don't know the exact numbers, but the ratio of ICU beds to population in the UK is so much lower than it is in Australia, like hugely lower. And so it's a different type of patient who gets into ICU in the UK to one who gets into ICU in Australia. Variation in health preferences. So you heard I mentioned QALYs. The way we get QALYs is people do I'll just call it a quality of life instrument for ease. Patient does a quality of life instrument. We take those results and they get converted into a utility score, which generally lies between 0 and 1. Every country has a value set that enables you to convert that answer into a utility score. The problem is the value sets are different in every country. So patients with exactly the same answers get different utility scores, which means you get different QALYs. That's obviously creating a problem because it's simply the value set you're using that's creating that artificial difference. Missing data and follow-up's a big one. For some countries, it's really challenging to be able to follow patients up long-term and to be able to collect data at 6 months. And that creates a real challenge if you can only do it in, for example, high-income countries. And then you, again, are getting a biased estimate of cost effectiveness if potentially those long-term outcomes differ in some of your low and middle income countries that are recruiting. And decision makers. So funders, like in Australia we have the, like NICE in the UK and the PBAC and MSAC in Australia, they have different willingness to pay thresholds. So, in Australia it's like, oh yeah, we think we'll pay $50,000 per quali. NICE has an explicit threshold that I can't even tell you what it is, but so one funder with the exact same results, one funder will say, yes, that's cost effective, and another country will say, no, that's not cost effective. So really challenging, and ideally we would do economic evaluations in each country. But the problem is we power our trials, we don't power adaptive platform trials, but in general, we have enough patients to answer the clinical question across all the countries. Now, cost data has a much greater variation than the clinical outcome data. So already we have less power in the cost effectiveness analysis. If we then try and do that by country, we can never show anything because there's not enough patients. So my take home is current health economic evaluation methods were designed for traditional trials and they probably don't provide reliable answers for adaptive platform trials. So we've got an international group trying to develop the appropriate economic methodology for this. And so people might continue to publish economic evaluations alongside adaptive platform trials, but I would question how accurate they are in terms of the methodology and how much they're accounting for the challenges I've outlined. But the thing is, if we want adaptive platform trials to change policy and practice, then we need accurate and robust evidence on value for money. Thank you very much.